Hello, my name is Vanessa Morales. I'm currently a student at GCU, and today we're going to be discussing my research proposal. In Arizona, about 1,308,000 individuals live with a mental health condition, and about 318,000 live with a serious mental health condition. So during my first round of internship or field experience, I was able to complete them at my place of employment, Connections Arizona, or the Urgent Psychiatric Center. At Connections, there is three levels of care we provide to the community. There's the walk-in urgent care, which is a walk-in from 7 a.m. to 7 p.m. every day except holidays where individuals can be seen for like medication bridges if they aren't able to get into their clinic by the time that their scripts run out, or just as a walk-in urgent care if they're feeling like their symptoms are increasing or they need to be seen by a provider for a crisis or anything along those lines. If individuals from urgent care need to be observed for about a day or so, they're able to stay on the observation unit, which is like a type setting where individuals are able to be observed for safety measures. There's no rooms. There's just recliners where the patients, there's a male side and a female side. The patients are like have eyes on them 24/7. Um, the observation unit also provides services as like if they ring the doorbell, if it's after hours, or if there's a police that responds to a crisis call or encounters a patient in the community that's walking through traffic or placing themselves in danger or others. Police respond both voluntary and involuntary calls. Um, Observation also serves for a place where crisis mobile teams are able to drop patients off. And then if a patient needs a longer length of stay and they need to be stabilized during their crisis, they're able to be transferred to one of the two crisis stabilization units where they'll be seen by a provider daily. Um, there's case management, there's visiting hours. It's just a bit of a longer length of stay for medication stabilization or to be connected to services in the community. Social problem and background. In the 1980s, mental health treatment shifted from like institutionalization to more of a community-based approach, but lack of resources and overcrowding like led to overcrowding of hospitals and like highlighted a need for solutions like crisis stabilization unit, outpatient clinics, integrated health clinics. Frequent readmissions to the psychiatric hospital after crisis stabilization services is influencing the bed crisis in Arizona, contributing to longer wait times and appropriate use of emergency department beds. Readmissions influence overcrowding of EDs, limited bed availability, reduced access to care, and pause in transfers until a bed opens up. A unique thing about Connections is that we're a screening facility for the court order evaluation process. CBI also serves as one and RI, but Connections is one of the three that serves the Maricopa County and neighboring cities. Um, so while I was on the crisis stabilization unit for my internship, I noticed a pause in transfers. Patients were held on a petition that's good for 72 hours, not including weekends and holidays, and sometimes required up to three petitions before they were able to be transferred to Value-Wise for the appropriate care. My research question is, does the utilization of ACT services after discharge from a crisis stabilization unit lead to improved patient outcomes compared to standard post-discharge care? My hypothesis is that patients who receive ACT services will attend more follow-up appointments and show higher adherence to outpatient treatment plans, leading to lower readmission rates. Literature review. There was two studies that I examined. The first one was of a crisis stabilization unit in rural Illinois that analyzed the effectiveness of the implementation of a CSU serving three local EDs, and a cost-benefit analysis showed that the CSU model described in this case study resulted in a 20% reduction in length of stay and prevented hospitalizations of 537 nights in 2014. Excuse me. This study supports the need for reduced length of stay and prevention of rehospitalizations. Another article I examined was whether ACT services used as an alternative to incarceration led to better outcomes and whether those participants who are not receiving ACT services. Literature review gaps. The first study in the CSU in Illinois used an appropriate approach, but only used local facilities in Illinois. And being a rural location may not like those findings may not apply to larger cities like Phoenix, where Connections is located. The second study utilized a retrospective cohort method, which limits the ability to strongly suggest that ACT services caused the improved outcomes. And the lack of participant feedback also withholds information that could be used to measure improved client satisfaction and highlights the reason for readmissions. Literature review. Micro, meso, and macro issues. Both studies identify macro issues such as bed crisis and high social justice involvement of SMI patients, which stands for severely mentally ill. My research proposal would be a meso level of change because it would be limited to connections, but can also influence a macro level of change by possibly influencing Mercy Care to change ACT services from only being voluntary. Micro change would occur with potential satisfaction and better outcomes of the actual participants in the study at Connections. Theory. The multidisciplinary treatment theory is a theoretical framework where professionals from different scopes of practice collaborate to treat and meet the needs of patients as a team. ACT teams are composed of multidisciplinary care. I'm sorry. ACT teams are usually made up of BHMPs, which are behavioral health medical practitioners, which can be like NPs, medical doctors, PAs. Also, they include an RN, which is able to administer like long-acting injections. They can provide med observation. Also, case managers that are engaging with patients 3 times a week, at least 3 times a week. Participating in staffings. Also, other social service members like discharge planners, care coordinators, rehab specialist, benefit specialist, and also peer support specialist. Data analysis software. For quantitative data, I would be utilizing the R software because it's free to use and will analyze quantitative data, and I'm able to use the Chi-squared test, which I would use to analyze readmission rates. Qualitative data, I would utilize DDoS, an analysis software, because it's budget friendly, and it stresses the importance of compliance, which is very important because we're using patient information. It would help me comply with HIPAA and align my and comply with the NASW's code of ethics. I would be utilizing a mixed method review because it uses both qualitative and quantitative data. Complete chart reviews using the EHR and which is the electronic health record, and hear from the population directly rather than making assumptions of causes of readmissions and um, how they feel that they're doing post-discharge. Implications. About 1 million Arizona residents are being affected by mental health conditions. The mental health systems in Arizona are overcrowded and often lead to longer lengths of stay due to bed availability, pausing the lives of individuals and putting a strain on multiple facilities and patients. Firsthand, I witnessed this while in the crisis stabilization unit when patients say they have to get back to their jobs, they're pausing um, job interviews and school if they're in school. Um, they stress about making payments on rent and just many things that add to stressors of being on a crisis stabilization unit and going through the court order evaluation process, which could be reduced by reducing the overcrowding in these mental health facilities. Policy implications. Currently, ACT services must be accepted by patients on a voluntary basis, meaning they must be agreeable. While at this on the CSU, um, we try to connect patients prior to discharge because um, they have to agree to it. So we submit a referral. They have to be screened for it. They have to be agreeable during the screening and consent to getting this level of care, regardless if the patient is often at the crisis stabilization unit or presenting to multiple facilities across Phoenix. Unfortunately, at this time, they have to be voluntary. Understanding of human behavior. Studies that are available today utilize chart reviews and do not focus on client feedback. My research proposal values the importance of patient responses and aligns with the NASW's value of dignity and worth of the person because we listen to the patient on their reasons of readmission or how they think they're doing rather than just making an assumption. Impact of culture, diversity, and oppression. Connections, UPC is a no wrong door facility, meaning they treat individuals regardless of their documentation status, whether they're undocumented immigrants or citizens or residents, if they're able to pay, if they're eligible for insurance, regardless of sex, gender, anything. This study would be able to follow up with patients post-crisis and identify barriers to treatment and causes for readmission, as well as study if ACT services improve their outcomes when reentering the community. Ethical considerations, informed consent, confidentiality, vulnerability of patients. I would use the NASW's Code of Ethics as a guide to ensure we're practicing with integrity, valuing dignity and worth of participants, respecting the client's self-determination, while fighting for social justice and advocating for our participants, since they often face oppression and stigmatization. Recommendations. Despite the ethical dilemmas of involuntary treatment, I strongly believe that in the long run, assigning high utilizing patients or participants would benefit them with ACT services to this level of care would provide better outcomes, decrease length of stay, and decrease hospitalization for patients at connections, potentially relieving some of the pressures caused by overcrowding of mental health facilities and EDs. And these are my references. Thank you.